watching us online, thank you for making time to join us as well. Tonight, we are here to talk about a very important topic, which is cervical cancer. And the theme we're looking at tonight is, if screening is cheaper than treatment, why do health systems wait? Cervical cancer is one of the most preventable cancers in the world. And we also know how to screen for it, we know how to vaccinate against it, and we know that early detection drastically reduces mortality. So tonight, we're gathered to ask whether cervical cancer is tragic, because we know it is. And we are not gathered to ask whether women deserve better, because we all know they do. We're gathered to ask something more unsettling, which is, if screening is cheaper, why do health systems wait? And shortly, you will get to see, and we'll get to hear from our expert panelists that we have gathered here, from medical professionals to policy experts who are with us. And as I said, my name is Nia Kofi, but I'm not moderating alone. I'll be moderating tonight with Dr. Ella Amoako, and we'll take her remarks as well. And then after that, we'll go around the room and have our experts introduce themselves. And then we can dive into our conversation.
Thank you very much, Lee. And thank you to those watching, and thank you to our panelists who have come here today. January was Cervical Cancer Awareness Month. We're not able to meet in January, but we think that women deserve to be heard, and we think that women's problems deserve to be heard irrespective of what month it is. So we asked our panelists to come here today to discuss a topic that really, really affects women of African descent. It's cervical cancer is across the world, but mostly affects women of African descent. Again, it's one that is very preventable. It's actually the one cancer that is preventable. And years of research has shown that it is. Unfortunately, it still kills women on the continent of Africa. And we are here to discuss how we can make things better. So we would go around and just have brief introduction of our panelists, and before we delve into our conversations. Thank you. So I'll start from my right.
Hello, everyone. My name is Abena Yosen. I'm a pharmacist, specifically in the area of drug safety. I am currently into the vaccine space, handling advocacy and corporate affairs for a vaccine manufacturing company. My background is pharmacovigilance, simply put, drug safety. So I've had the opportunity to work with public health experts in the area of vaccine safety through our vaccination programs in the country, and I'm happy to be here. Thank you.
Hello, everyone. My name is Frederica Crunchy. I'm a midwife. I work at Kolebu, the Reproductive Health Center. And I'm more of a cervical cancer advocate myself. We do the screening, the vaccination, the treatments, all of that at the reproductive health. And we've been doing this for so many years. If I can say this to boast, Kolebu, we started with the awareness creation on the cervical cancer, and it's been 8 years, and we're still going on. And we're happy to say that a lot of people, a lot of institutions have picked it up, and they are all talking about cervical cancer, and that's a good thing. We're happy.
Okay, so my name is James Nikwe. I'm an OBGYN. My subspecialty is gynae oncology, so I deal more with the consequences of cervical cancer and the screening. So I'm happy to be here. Thanks.
Good evening. My name is Ifya Apia, and I'm a a public health communicator and pretty much an average Ghanaian woman in the prevailing healthcare system. Thank you.
Good evening. I'm Nita Asamoah Menujima. Yes, I'm specialist obstetrician gynecologist. I also work in Kolebu Teaching Hospital, and we are all part of the Women Advocacy Group for Cervical Cancer. I'm happy to be here.
Hi, good evening. I'm not a doctor. My name is Joseph Abene-Ebua. I work in the health insurance industry. I'm the managing director of GAP Health Insurance. I'm happy to be here because for the company I work for, typically, health insurance will focus on preventive care or curative care. But we do more of preventive and wellness. And so it's a good conversation to have. This is my first time here, and I hope I will enjoy the conversation. Thank you.
Hi, good evening. My name is Charles Kwame Susu. I work at Leicester Hospital and Fertility Center as a family physician. So I come across a lot of women, which has whipped up my interest in women's health. So I'm glad to be here to discuss this very important topic. Thank you.
Hello, everyone. Health economics, and I've worked with women for the past 2 decades, and I'm also a woman myself. So I'm interested in this topic.
Hi everyone, so I'm Felix Enineje, an internist and a gastroenterologist, hepatologist. I'm sure the first question is, what is the liver doing in the cervix? But I'm sure we can all share something, learn and share. I'm happy to be here. Thank you.
Good evening. My name is Susan Edamankwa. I just happen to be here. So I followed the public health advocates to be here to listen and educate myself. Thank you.
Thank you all so much. And I must add, say that this particular series, it's a 3-part series. This is the first session we are having, which is looking at the cost, like avoiding the cost at all costs, I must say. And this conversation series is brought to us in partnership with QIC Insurance. So I must stress that first and foremost. Next week we will have a second round of conversation. We'll get into more details about the topic and how those of you at home can join if you want to be here with us at the debate house or to watch from home. And then there'll be a third part which will be in March. So we'll keep you all updated as we go along. And yeah, we'll give you from various. You can join us. So to give us a breakdown of cervical cancer when we talk about, because in our introduction we all said that it is one of the most preventable cancers, and yet some research suggests that about 3,000 women are diagnosed with it every year in Ghana alone, and over 1,000 die as a result of being in fact affected by this particular cancer. So Dr. Nikwe, probably I'll start with you. If you could break it down for us, what we mean when we talk about cervical cancer.
So cervical cancer. So this really the mouth or the opening of the cancer that affects that part of things, so we call cervical cancer. And like we are all saying that it's something that's preventable. Why is it preventable? It's because it's the opening and it's easily accessible. It's easy to, one, deal with it. Two, it's easy to screen for it. treat pre-malignant lesions. Pre-malignant are before it forms cancer, before cancer comes. Okay, so it gives us the opportunity to try and interfere with the progression of cervical cancer from infection to when it comes cancer. So that would be my cervical cancer of the opening of the womb.
Thank you, Dr. Nikwe. I like that you said it's the opening of the womb, so it's easy to screen and we can detect it and see pre-malignant lesions and sort of prevent it from getting into cancers. But the statistics are still quite gory. A third of the women that are diagnosed actually die, right? And the question, Dr. Samwamino, is to you. Why do women still die from cervical cancer? If it's the opening of the womb, so it should be accessible. If it's something that we can see early, so we can prevent it from spreading. Why do women in Africa, in Ghana, a third of the women die? Why?
Hello. Yes. So, well, when I looked at a few statistics and a few reasons around, I saw that there's been an issue with implementation. Yes, on paper it's nice. We are trying to prevent cervical cancer. We are screening women. We're going there. We are doing that. You see advocacy groups talking about it. You see people discussing cervical cancer, especially in January. But we are still losing our women. One of the few issues I realized was certain misconceptions about the whole issue of cervical cancer. First and foremost, going to lie down for somebody you do not know, to open up your legs to the person, for the person to go into your most intimate, is not easy. Most women find it very, very difficult to do that. One of the things I realized is that increasingly our women are requesting for female gynecologists. So most, apart from the general hospitals, most private hospitals specifically request for a female gynecologist, so that most of the women that come, apart from maybe pregnancy that they do not really mind, if they are seeing a gynecologist, they prefer to see a woman. So one of the few issues was the fact that they had to open up their legs for the screening. That is one. Some people also believe that if they are diagnosed with HIV, it means that they have been promiscuous, because it is a sexually transmitted infection. So, okay, then I'd rather not know that I may have HPV. So they think ignorance is bliss. And then they may go somewhere along the line and then they are picked up when they have the carcinoma in situ, or even after pap smear. Another thing is that they do not come for follow-up, or sometimes the women are lost to follow-up. Because our address systems are not the best, sometimes when you identify these women, if the phone number is wrong or you get the address wrong, you're not going to find this woman again. And next time she comes, because it's so slow growing, sometimes it can be as low as 10 years. By the time you find this woman, or by the time she presents to you, she's coming with symptoms. And when you start coming with symptoms, it means you already have the issue. Then we also have healthcare system challenges. The screening is a little bit expensive. The vaccine is a bit on the expensive side. People don't think about it in the long run. That, okay, if I get a cervical cancer and I'm coming for treatment, it's more expensive than if I come for preventive care. They think that in the interim, if I'm going to pay about 350 or 500 or 600 for a screening purpose, it's too expensive. I may not be able to do it. So then let me just wait and see. Then later on when they come, they are in a bad situation. Then we also have access to healthcare centers. Currently, it's mostly the tertiary institutions that do the screening. When you go to the CHIPS compounds, the smaller facilities, they do not screen. So if you have people in the village, how to get access to a bigger facility or a tertiary facility will be a problem. They will only present to you when they have the disease, and by then it would most likely be too late. Then we have the healthcare also coming in. Healthcare pays for treatments. They pay for treating cervical cancer, not preventing cervical cancer. It's recently that we've had a few rolling out of a system that takes care of, I think, 9 to 14 years or so. But previously, it was treating cervical cancer, not preventing cervical cancer. And even that is for a specific group of people, or is for people who can have access to that part of the preventive treatment. So that's, I mean, I have more, but I have to let others talk.
You actually hit the is exactly what we are here to discuss. That if it is cheaper to screen compared to treating cancer, why aren't we screening? And Frederick, I'll come to you with this. If I know you making on, let me get to Frederick before I come to you.
Actually, I was going to come
now, okay.
because sorry. Let's be wary when we throw out figures, and let's be wary when we throw out figures because we stand the risk of alarming people. When you say 3,000 women are diagnosed every year, and out of that 1,000 die, if you present late and the cancer is quite progressed, chances are treating it or curing it will be challenging. So you can have 3,000 women presenting at a precancerous stage or quite early, and they can be helped. But if it's a late presentation, that's when it's a challenge. I don't want to say that's when people die. So you can have cervical cancer at a very early stage and still be helped. So it's not everybody who presents, or it's not everyone, or having cervical cancer is not a death sentence. So just so that we manage the fear of having cancer, I think we should also put in that caveat that even though you present, it's not an end. It's not the end game for you.
Thanks. So, Frederick.
So I would want to start with the fact that it's not just the male gynecologists that they are wary of. It's the fact that they have to lie down for a procedure, or the fact that they are just thinking about something going down there is what they are worried about. So whether they meet me or they meet Dr. Nikwe, it's still going to be the same reaction. So usually when they come, we take our time to explain to them what cervical cancer is, how it develops, what happens if they don't screen, and then we also explain to them what happens after screening and the treatment options if seen early, and the fact that this is preventable, this is treatable. So to get somebody to actually allow herself to be screened, she needs to understand what she's doing. So we take our time to explain things to them, for them to know what cervical cancer really is. My place, people who come there for screening, we don't just, oh, you're coming for screening, we'll put you on the bed, we'll go ahead, remove your panty, lie down, we do. No. We sit down with you, explain things to you. If you have any questions, we answer. If you have any fears, we take care of it before we put you on the bed. So it's how we go about the whole thing. I've had a lot of instances where people came and they said they've had this test done before and it was so expensive. It was so painful, so they didn't want to do it again. I spoke to them, tried to calm them down. They did. I didn't feel anything with this one. This one was actually better. This experience was much better. It usually starts with how you talk to them, how you engage them. So the whole education bits before the screening really helps, before you can actually do the procedure itself.
Thank you. Okay.
So I actually have a problem with that mentality that the first time majority of women see a gynecologist is when they're pregnant. And that, I believe, is part of our problem. When we look at cervical cancer, we look at the prevention of cervical cancer, we are looking at young women, or teenagers, pretty much teenagers, between the age of, is it 12 and 14? 9 to 14. None of the teenagers I know, 9 to 14, are even conscious that there's someone called a gynecologist who they have to see. I can bet my last dollar that, or my last cedi that, 90% of women who see a gynecologist, the first time is when they are pregnant. And that is part of our problem. Or when they want to be pregnant. And that is losing your first maybe 28 years or 25 years without that consciousness that cervical cancer could be happening to you. And that is where the risk is, because when we are talking about the cost of prevention, education from 9 to upwards is what we should be looking at. That is actually the real cost before we talk about the cost of the vaccine. I was in an all-girls school for the first 18 years of my life. The only thing we heard about was candidiasis. That was the only thing. No one ever talked about breast cancer. No one talked about cervical cancer. And I remember we had to take prophylaxis for some time. I don't know if it was a vaccine test or something for malaria. And we used to take it every Sunday. That was pretty much the only thing. We knew malaria, we knew whites, but no one ever spoke to us about cervical cancer. The fact that there is that hesitancy to tell women that you have to see a gynecologist is someone who you should know. You should have a number of a gynecologist before, or when you're young, before pregnancy, is one of the things that we should look at as the cost of prevention, because that is critical.
So like you said, it's all about education, okay? And for prevention, like we are talking about, the education, the screening, the vaccination, okay? Like for example, we undertook Ghana vaccinated girls from 9 to 14. Most of these girls don't know why they even had the vaccine in the first place. You understand? Unfortunately, when you vaccinate, you're going to see the effects 20 to 30 years down the line. So it's a long-term kind of thing. One thing we're also trying to push is that we everybody should remember that vaccination does not mean you shouldn't screen. So we all need to get that understanding. But when it comes to the barriers, it's not just the feeling uncomfortable. One, our health-seeking behavior as blacks is poor. That we should know. So if you realize when you are reading about cervical cancer, they tell you say low socioeconomic status countries, basically. And you find when we move to foreign countries where there's screening and things, we still don't screen as much as the Caucasians. So Prof. Che, urology, says naked but not ashamed. The reason why you see a lot of obstetricians or gynecologists advocating is because we get to catch them when they're pregnant and have more contacts with them. So our screening method now is more opportunistic. So NITA comes, so NITA, bring all the gay girls who are going to make noise this week for screening. Let all of them screen all of them. You understand? And we can get a whole batch of gay people who not only make noise about their I'll get in trouble for this. But the whole point I'm trying to say is that we are being opportunistic. So a church comes, we screen. It's not a planned, structured something. And studies have been done. Our screening is about 3.5%, the whole nation. So let's get past the gynae male, female, the speculum is painful. It's just for about 5 minutes. When you're educated about it, it's basically the same procedure like taking a swab. It's uncomfortable. Then comes the price. Okay, then comes the price. Then comes the lack of education, where most women want the permission of, not most, forgive me, some women want the permission of their partners before they can undertake some of these tests. And then the men not knowing what this test is all about will refuse or not foot the bill. So the problems are multifaceted. And in terms of the education, if we are going to get somewhere, we need to get to the grassroots and solve these problems before we can make a headway.
Dr. Nikwe partly answered what I was going to say, because I was going to ask whether there's a national program for it. Because if they, sometimes with a national program, then you can have more structure and look at certain things. But if there's no national program, I know now they are doing the HPV vaccine campaign, but it's it just started, and I don't know whether it has that base of a program, because you can do the campaign without having that base where you have a program like we have malaria. First we wanted to eliminate it, now we want to totally eradicate it. So if we had something like that, then it will probably help to you'd have more sustainability and a more sustained pressure on it. But if we don't, then we can do the campaign and it'll be a good campaign, and then it will falter again. But we need to have a more sustained program in place, given that also we have a very young population, a young population. Of course, if we are looking at the demographics, we have more females than men, so you have more young females there. But this is also important for the young men, because after all, it's also sexually transmitted, so you must also get the boys very, very much involved in it, at least to my thinking, that you need to have the boys very much involved.
I'm happy that Madam Susan mentioned, a program aspect of it. I've been thinking about it. To know that there has been, the first step of even having the 9 to 14-year-olds vaccinated is very good, because in 2013, that's when Ghana piloted this whole HPV vaccination, thing, and it's taking us plus 10 to actually roll it out. So it started in, 1 or 2, maximum 3 regions, I think Greater Accra, Northern, Central. We are now rolling out, which is very good. It's taking us a long time to roll out. And I'm asking myself, if the pilot was for 9 to 14 still, looking at the progression of the disease, right? We are looking at 10 to 20 years later, you are picking up adults, who are in their 20s, who are now at higher risk. So those who didn't have the opportunity to receive the vaccines then have still been exposed. Looking at the life, so it's good that we have started. Now the bigger picture is to consider whether we should still have it as a piece of an immunization program, or we should bring it out as a standalone program, as Madam Susan was talking about. And I think it's something that we could really consider, because there's a lot we can do. It's a hand-in-hand approach. We're looking at screening, we're looking at vaccination, being able to pick up early cases, and then what happens in the clinical setting. So I think that we can also look along the way of having programs throughout a very longer period that should serve as some good purpose.
Joseph, I know you raised your hand, but I have a question for you actually. So maybe you can tie your answer in with the question I have for you, which is cost has been mentioned a few times in different contexts, but I'm coming to cost as in the cost for screening of cervical cancer. I'm not, from what the research I did so far, I understand the NHIS doesn't cover it entirely. I don't know about whether it doesn't cover at all. Okay, so that's why I'm coming to the cost, for instance. So people get health insurance. Is there a way, what would make insurance companies essentially want to cover the screening for women, since our national health insurance, for instance, doesn't cover it at all?
All right, thank you. Actually, that was going to be my intervention, because all that we have been discussing now has to do with money. Because time for implementation, I believe, had to do with money. Even this virus vaccination that we are doing had to do with money. And I believe that they had to wait for funding from elsewhere before we can go ahead and implement even the vaccination. And so for us to be able to make the impact, we must, in terms of policy direction, for what I do, private health, currently we cover just about 500,000 lives in Ghana. Look at the population that we have. But if you take NHIA, which is running the NHIS, they cover over 20 million lives. Out of that, we have close to about 58% being women. And so if you want to really have that impact, prevention, if we are not able to do that, screening and then treatment, and we want to have it on a large scale, cost is very important. Now let me speak from the private health insurance part. Because it's private, every health insurance company, unless it is a mutual scheme where members have come together to form a scheme to take care of themselves, where they are not interested in profit. But for every private business, at least breaking even is important. And so whatever plan or policy that is designed for the insurance public must first make sure that it's affordable. And so if you are charging premiums that you are incorporating screening into it, it means that premiums are going to be high and you're not going to have the impact that you're expecting. And so when I did my introduction, what we do at Gap Health Insurance is, of course, we'll come to that discussion. I mean, data shows that treating these conditions are very expensive. And so, yes, having the screening may be expensive now, but if you're able to catch it early, it is much more less costly than treating the condition. And so we try as much as possible to do the screening. But even that, you have educated people. The scheme I run is owned by the banks. And so you feel that banks that are elite, are educated, will even submit to the screening. But just 2 weeks ago, I did a screening for one of the banks, and I was shocked to see the number of people who opted to have the pap smear. And I was very surprised. So, of course, education is very, very important. Now, back to trying to manage the cost. It must be on a national scale. Because if I take NHI, all of us pay for that. And so, can we have a discussion to try and move away from the treatment, the curative, and say that, okay, we want to dedicate part of the funding that we get from the taxes. It may not just be cervical cancer, but others that we believe that should be able to reduce the burden on the scheme. Because if you're able to screen early, we're able to catch the disease early, and then treatment becomes a bit easier. So in terms of cost, yes, health insurance can provide, because what private health does is just complementary to what the national health insurance provides. And so if we want to have that impact, we must have a very good plan and a policy to bring screening and even the treatment of these cancers within the covered diseases or conditions under the NHI.
Thank you. That's really helpful. I'll come to you. I was actually going to come to you. But I do like the fact that you guys screen, and I agree that the nation should take it up because it's way cheaper to screen than to treat. And it's not just the money part, it's the health economics of it. It's the woman leaving her family in Hafasin, coming to Accra for radiotherapy, and sitting here, and those children not having a mom. And then if she dies, we know that our society is very matriarchal, so they've lost that matriarch, and we know that the family is going to fall apart. So it is on the people we pay our taxes to. It is on the people that receive money for NHIA to make sure that it is something that is done for the women of Ghana. Dr. Sosu, as a family physician, you are a preacher of preventative. What do you think we could do better as a nation? Just adding to what Joseph said.
Thank you very much. So to add on to what my other colleagues deliberated on, as a family physician, I come across all manner of patients with all manner of illnesses, and I would say, without doubt, that every female that comes, so long as probably you're not above the age of 65, the question will come: have you had pap smear before? Regardless of the illness you come with, you can come with headaches or whatever, but that should be part of the questions we will ask. Okay, have you had a pap smear done before? If no, have you had a cervical cancer before? They'll tell you, oh, not really. So that's the time that we get to educate them. Okay, so I would say we have failed as health workers. Okay, and we have 3 levels of prevention, and the most important, I would say, is the primary prevention. Okay, that's when we give the vaccines, and that's what Ghana started. We started last year. Education, education, education. I always say, if most of our women, or let me say the general population, is they have a little knowledge about cervical cancer, it will make the work easier. And I think it's high time we take this seriously. Our kids, the teenagers, early teenagers, from 9 to about 14 years, that's the time that we should get to educate them. We should also educate them on healthy sexual practices. It's not all of them who listen. Some definitely will want to go and do things. So what do you tell them? Use condoms, because the way you get cervical cancer is by HPV, that's the human papillomavirus, and you get it only through sexual contact, even though we have a lot of strains of the HPV. But the high-risk ones, 16, 18, etc., is what will normally cause the cervical cancer. So we should educate them on abstinence, 1, 2, use of condoms and all that. That should be very key in our education, as well as the vaccination. That's the primary. Then when we come to the secondary, that's when we want to screen to detect early disease and treat. What are we doing as a country? We don't have a policy. Back in the US, they have this policy that if you're above the age of 25 or 24, as part of your screening, general screening, health screening, pap smear is added, regardless of whatever you present with. And that has remarkably reduced the incidence of cervical cancer there, because they've added it to their screening protocol, all women who come. But we don't have that in Ghana. Even when you go to hospital, I don't know how many doctors will ask the female, have you had a pap smear done before? So that's from the health workers aspect. Then as a nation, we've also failed because there's limited budget into prevention of cervical cancer. we've rather focused. I mean, it's also good focused our energies on malaria, HIV, TB, and some cancers. I'm not saying it's bad, but as you marked, it's a preventable disease. So if you're able to put some budget in reducing the cost of pap smear, let's say NHI would fund that, I think it would go a long way in helping reduce the incidence of cervical cancer. But education, as I say, is the most important thing, because prevention is better than cure, as you say. And also, as part of the courses, we have limited resources in terms of personnel and equipment. You go to certain hospitals, they don't even have the speculum. If they even have it, it's expensive. How many people can buy that? So, as Dr. Nikwe said, low socioeconomic status is also a major factor in all this. So, if you hammer on education, I think we'll go a long way in preventing cervical cancer.
Thank
So
you,
that's
Dr.
my take on that.
Thank you. Abna Sumini, I have a question for you, but let's take let's take Frederica, and then probably I'll come to you, or I'll go to Dr. Anita, and then I'll come to you. Yep.
Okay, so when he was talking about the education bit and the fact that most doctors don't tell their doctors to screen, it just drew my attention to something. Aside the gynae clinics that most of the doctors would write it as part of the routine test for their patients to do, the other units or the other departments do not really focus on that. And we, at the reproductive health units right now in Kolebu, we decided to do this thing where every morning we send out some of our nurses to the various OPDs. So the medical OPD, the surgical OPD, the cardio department.
OPD being outpatient departments, for those who don't probably know what it means.
Yeah, so the outpatient department, and even the child health, where we go to talk to the people who have come there for other illnesses about the cervical cancer. And we got to find out that most people really do not have any idea about it. So you talk to them there, and then they get to hear about it the first time. They ask a lot of questions. The next thing you know is they come to your unit. Oh, one of your nurses came to talk about cervical cancer. I want to do the test. And I think at a point we noticed that some of the doctors started picking up on it, where they were requesting it for their patients, but very little of them are actually picking up on that. And with what he said, it would be really good if almost all the doctors decide to make it as part of the routine screening, even if they just came with a headache. It's very necessary, especially if the person has never done a pap test before. Yeah.
Thank you. Dr. Anita, you want to say?
So I wanted to talk about how to reduce the incidence of cervical cancer. One of the most powerful group of health workers we sometimes seem to overlook are the community health workers. Those people are, should I say, they are probably lower on the healthcare provider system, but they are so powerful because they go into the communities, they do, they partake in these vaccination programs. The community members trust them. The women go to them for so many things. So they are part of the people I think we could use, or if we are not already started using them, to educate the women on what cervical cancer is, how it's transmitted, to let them know that there are available screening methods for it. And then if they are screened and they test positive, we call them screen positives, either for pre-malignant lesion or even for early stage disease, there's treatment for it. Because you see, they go around for giving, I think, IPT for malaria, they go around immunizing the children, follow-up for TB and a whole other things. If you have HIV, they go around for follow-up for you. If you have HIV and TB, they do that. HIV, TB, HPV, they all tend to coexist. There's a high prevalence of one when the other is there. So we could use those people to advocate for education, especially, so that as they go into the hinterlands, they talk to these people about it. Those of us in the tertiary, I think the education is there, is a lot there, but those women down there who would come with advanced disease, they are the ones we may need to also pay attention to. So we could use these community health workers. I did a bit of house job rotation in Battle. And then when we are there, every woman that comes of childbearing age gets a pap smear done or a speculum examination, let me put it like that. In Kolebu, every woman who sees the gynecologist the first time, or at least at some point in the system, needs to have a speculum examination done and then a pap smear done. So this helped us to pick up a lot of these, especially pre-malignant lesions or early stage diseases for that. And so I think it's one of the few things we could also do to help pick up early stage and then screen. If screen negative, we vaccinate. I also wanted to speak about the adolescent health, because most of the time it's this time that people engage in a bit of risky behavior, exploration, a lot. Risky behavior, exploration. I want to know, when I do this, what happens. They are curious. They want to know a lot of things. Sometimes when you talk to them, when they come for in Cape Coast, we used to have this adolescent antenatal clinic, and if you go there as, let's say, even a 25-year-old, you are old. They jest you, they laugh at you, so you kind of have to find an adult clinic to go to. These are areas where we could talk to them, and they almost all the adolescents have a group leader. When you start menstruating, there's a leader who talks to you about sex. There's a leader who talks to you about contraception. There's a leader who talks to you, and you get to know which men have money or where you have to go to or what you have to do. And these risky behaviors is what is predisposing them to sexually transmitted infections. That's one. HIV, cervical cancer, and all that. So sometimes you speak to them and you'll be amazed at the things they know that you were wondering what you were doing at that age. So in the adolescent clinics, we could talk to them about that. And then the adolescent antenatal care, we could talk to them. We talk to them in their schools, because those are the places they are at most of the time. They go to school at, say, 8, close at 3 or 4. We could somehow find a way of incorporating it into one of the subjects. I don't know, maybe life skills or something, one of the topics, so that at some point in time they are aware. So that in school, it's not only girls that are in school, it's boys and girls. So that in school they are aware that there's something called cervical cancer, there's something called sexually transmitted infections, so that by the time they grow older, they at least they have some idea about it. They can still even practice what Dr. Sosu was saying: abstain if you can't abstain, use a condom, or you have safe sex practices. And also, yes, be faithful to a partner. And I would like to also give a shout out to the gay girls who are having their speech day this weekend. Live pure, speak true, right, wrong, and then follow the king. We are all coming. We're all going to Cape Coast this weekend. Yes, and then they should also screen.
Okay, thank you. Advanced meaning, let's look at human or health cost, the human capital cost, if I can put it that way. If we still, because from what I'm hearing so far, as far as screening is concerned, say 10 years down the line, if we still do not develop or agree on a screening policy as a nation, what does the economics look like on the health front? Okay.
Please, there's a screening policy.
There is?
Yes. Let's leave it at that, but there is.
Okay.
It's on
paper.
There is a screening policy. Thank
Okay.
you very much.
So if the it's not being implemented, if I can put it that way, well, on the line, what does it look like for us as a nation?
I think that we have to look at it from the past to present, right? And we sit here, even our discussion is very urbanized. You know, this language we are all speaking English. And so in terms of even access, my PhD is in access to healthcare. And even language is a barrier. I did some work maybe about 4 years ago on how, even with delivery, people who can't speak in the theater. And I created a very interesting picture of how nurses and the doctors don't know how to even sign. So when is she supposed to push? She doesn't know. Somebody saying push, somebody saying no, hold. So think about it like that. Access to healthcare is a problem. And it starts, first of all, we've all mentioned it, in the area of awareness. And Nita talked about how community health nurses should be. Look, on the policy space, or in the policy space, you realize that primary health care, in terms of the CHIPS compounds, and one government comes, they are promoting it, another comes, they are not promoting it. One comes, they want to invest, another comes, they don't want to invest. One comes, they don't want to put emphasis on it. It's a very confusing space. So it creates problems for access to healthcare. Now, even when the systems are there, and I did a bit of research, maybe 2010, on healthcare infrastructure and the CHIPS, where primary healthcare can be sought. And that's where basic education. Somebody would say, if you are pressing your nipple, maybe something is coming out. People don't know these things. That is even rural areas. Urban areas, you'll be amazed at the interpretations they put on symptoms. A whole lot of confusion in the system. So awareness creation is very important. One of the first points of call for getting information is our drugstores, because the data shows that the first point of access to healthcare for most Ghanaians, majority of Ghanaians, are the pharmacy or drugstore. So if we are going to get education, we need to start looking at it. I'm trying to introduce the innovative solutions here. We have to get to that point. Last week, I had an interaction with a woman, very educated. She has a master's and she's working. And I asked her when was the last time she did a thorough medical check. She says, hey, Miss Ro. I said, so what are you afraid of? She's afraid of the unknown. I said, so is it better to live in the known, which could be an unknown? You understand, this is an educated person. So when we talk about these issues, we need to find a way to understand this. Now I come to personnel, which is your question. As of 2020, the data show that one physician is to 14,000 ordinary citizens. So how are we all going to even access even medical doctors, right? So nurses, I think nurses stood much higher, right? And now we also have the situation of the brain drain, and the last 5 years, very alarming. You guys, try. Your people not try. So it is the flight of professionals. And listen, they go and they are doing very well. And so it's not as if they go and the story is bad, so they would come back through Libya and all the. No. They are being treated very well. And the investment that we need to make in infrastructure, we are making into educating our professionals, and the professionals are not staying because we don't have a system of sustaining them. Going to school is hard. And the investment only, if government makes it as simplistic as in terms of tuition and all of that, how much your parents must have spent on getting you to be a doctor alone, So all of these dynamics, you look. Well, return on investment, I don't even know. I don't even know when that time will come, when we'll be able to pay them back. And so that it's a mixture of very difficult situations. But I think that we don't have a consistent policy framework. Next 10 years, this HPV thing we've started. I didn't want to come to private health insurance because that's also another case. How many people have private health insurance? And even the products that they are designing, how many people know? I don't know, qualify for it? How many people can access it? How many people have what it takes to say, I have normal national health insurance, I'm also going to take this kind of policy for myself? It's a difficult situation. Too many things to touch on, but they are all interconnected in such a manner that we can't access healthcare. And it's not as if people don't care about their lives. Sometimes they just don't know, and then when they do know, they can't afford. How many times we were talking earlier about if you're Kolebu situation and things, right? To get to Kolebu, if I live in East Legon, to get to Kolebu to access healthcare, even when I come to the point of even thinking that, well, maybe a part of you you are not feeling well, how will you, yes, right, how the economics to put together to go, if you are a mother, you have small children who may close from, say, school at, say, 2, who will be there to take care of them, to pick them from school? For you to go to a Kolebu, if you must queue, the traffic, the everything, put it together, and it is a very difficult access situation to talk about. And so it's not so simplistic. If you don't know, you don't know. You may live in it like that. But when you do know what it takes to even go for information, for some kind of diagnosis, we don't know. So that's what I would say.
Thank you very much, Abna. And I'd like to acknowledge the presence of our Deputy Health Minister, Dr. Grace Ayin-Sudankwa. Thank you for joining us this evening. And I believe you had a question for Dr. Enineje, right? So we will ask you a question momentarily. We have one for Dr. Enineje, then we'll come back to you.
Welcome, and I love your fugu. We're all going to Zambia. It's beautiful. I love what you said. And you hit the nail on the head that we are very urbanized, and we are sitting here from Accra, in Lister, someone who goes to Kolebu, but we forget the woman who sits somewhere. I keep going to Hafasin because most of my patients are from Hafasin. But and there's that woman up north who is the one holding the family together, right? And she has to leave. You said Islay. You even said Islay gone to Kolebu, and who is taking care of, yeah. What of the one who has to leave Upper East to come all the way to Konfanochi for like brachytherapy, like treatment, and she has to leave her children, her family, for God knows how many days for a treatment that she doesn't know how long she would receive or whether she would survive. So I think we should really come out of that urban mindset and look at the people at the grassroots, those people who actually feel the brunt of this. If she were supposed to go, like she probably went to farm, got some plantain, sold it, and you want me to use that money to screen for what? So that I'll find out, and then what? Like then what? You know? So we need to have these honest conversations beyond the Accra, beyond the Kolebu, beyond just the capital. I know that you did say that we were wondering why you were here, but I think time Ghana has introduced this B vaccine, and it's also again one of the most preventable cancers, the hepatocellular carcinoma, cancer of the liver. And I was just wondering what you thought about rolling out the HPV vaccine and what lessons we could learn from what you guys have done in your field.
All right, thank you for giving me some. That is something we can at least borrow in the. I think one thing that helped with the hepatitis B. I mean, in relation to prevention of hepatocellular carcinoma, is the fact that at least for the pregnant women, they are tested for free. The testing is for free. So, I'll just have to reiterate the point a lot of people have made. It's about money. I don't think screening should be some discretionary luxury that if you're lucky and you get to a doctor who remembers, you are screened, and if you're unlucky and you get to a doctor who doesn't remember, you lose out. There should be some kind of it should be kind of codified, so that you know that everybody who gets into this space, this is the test we are doing. So for example, if you wanted to check for human papilloma virus, then we could incorporate it into our normal OPD schedule, that okay, every lady between the ages of 9 and 14 gets screened, and of course once you screen and you are negative, you have the vaccine. I think that is what has helped with the hepatitis B. Again, it's not like the hepatitis B is not it's not without problems. It also has its own issues, because the vaccine is not for free. You have to, well, in children, I deal with adults, so I didn't know this. Okay. As in the EPI. Okay. Yes. Thanks for the correction. I've left PDX years ago. Yeah, so again, you won't believe it, but even the cheaper one, of course, to the cadastal or whatever you call it, yes. But even that, people don't have the money to pay for it. So for me, I would still go back to that policy direction that would kind of make it accessible in terms of availability, accessible in terms of the finances, who pays for it, and if the insurance would also focus a little bit on preventive health. Preventive health should compete over emergency. Emergency will always win. So we have to be deliberate. Yeah, it has to be intentional that, look, this money is for prevention, period. It can't be a whole pool of funds and then emergency struggling with preventive medicine. Preventive medicine will lose out big time. Nobody screens when you have some head injury, you have to deal with, the person is dying. You don't keep money for screening. So I think it's a deliberate move to keep some funds just allotted for screening. And of course, in this instance, you're talking about cervical cancer screening. I think that would go a long way to help. Thank you.
I just want to add to the vaccination 9 to 14, and the screening is usually 25 for pap smear, then HPV, pap or cytology from 30. Yes, if we can't screen 9 to 14, so I beg you before someone gets us wrong. And also, yes, not him. And also, an immunocompromised patient, let's say HIV, you start screening the period you diagnose them. So they don't follow the usual screening, and their screening is frequent, mostly yearly. Okay, thank you.
Adding that, not just HIV. I mean, when we talk immunocompromised, we just hit HIV. There are other conditions like autoimmune conditions. There are conditions where women have to drink medications to suppress their immunity, and so that group is also at risk as well. I would let you take the next question.
Okay, well, thank you, Dr. Ella. Honorable Dr. Ayinsi Dankwa, in preparation for this, I guess I probably have to own up, like most men, haven't really bothered to read much beyond what very little I knew about cervical cancer until we were going to have this conversation. So I did a bit of a deep dive, rather I should say, beyond what I already know. And I came across this interesting 2023 report from the WHO Ministry of Health on cervical cancer screening. And one of the things that it said was that there was a health policy developed in 2005, which was implemented, I believe, between 2007 and 2011. And one of the things it was supposed to do was the recommendation was for cervical cancer screening with visual inspection with acetic acid, along with treatment for precancerous lesions with cryotherapy for women aged 25 to 45, and cytology screening with pap smear for women aged 45 and older. And as I said, this was a plan for between 2007 2011. I wonder if I because I'm not in the medical field, I don't know if after 2011 we've developed a new, policy on this, or if we are still working with that. If you could give us some national update in terms of what our national policy on cervical cancer screening is.
Thank you. I'm not sure if I'm here as the deputy minister. I'm here as a physician.
Okay.
And I'm not an obstetrics gynecologist. I'm a general and reconstructive surgeon.
Okay.
So I don't do cervical cancer screening. But from the government point of view, I can only talk about the generalities. When you look at cancers in females, breast cancer is number one, and then followed by cervical cancer. So, and the burden of disease is pretty high, and for cervical cancer, it's pretty fatal. I think last year or so, we had about 3,000, and over 2,800 of them died. So, the mortality rate is really high with cervical cancer, because almost always we find it late, or late presentation, because of all the issues we're discussing, the lack of early screening. So because of these issues, and because of the rise in non-communicable diseases, including cancers, the government, or in our NDC manifesto, we had a policy which we called the Mahama Cares policy. It's actually the Ghana Medical Trust Fund bill. What we realized was that most of the time, when people have these non-communicable diseases or end up with cancer or some sort of rare immunological diseases, they get to a point where the national health insurance can't cover, they themselves cannot pay. And what we see a lot on TV, people soliciting, and those of us who are politicians, I get so many calls every day. We need medicine for our health care. And it's mainly with these non-communicable diseases, and also when it's cancer. And oftentimes it's a big burden on the family. So the Ghana Medical Trust Fund, which we call the Mahama Cares, is a fund that was set aside because they max out of the national health insurance. They don't have the money, and then they go through a lot of things. Sometimes the family has to sell the house. And most of the older generation too, they're already retired, so they don't have money in the first place. So the Ghana Medical Trust Fund, is which we have passed the bill. The bill has been assented to by the president, and we have started implementation. I believe on yesterday, about 6 children medical bills were paid, I believe, in Kolebu. And so what the implementation of what we are doing is that when people have cancer, for instance, cervical cancer, and they need help, the fund is one, support them, give them funds to pay for their medical care. But giving them money to pay for their medical care is not enough, because we actually in this country have a deficit of even how we diagnose it in the first place. And not only the diagnosis, but even getting access to the right physician at the right time. For instance, if you have cervical cancer, my constituency in Eskaduketan, in a village called Ahanta Abasa, there is no way you even get to the proper doctor to give you that diagnosis that you're looking for. I mean, it's those of us in Accra who get diagnosed. Most people don't even get diagnosed in the first place. So the idea is that we look for the deficit, or we do a needs assessment and see what happens when people get to that stage, because that is like subspecialty and super subspecialty for those of us who are physicians. So we need to figure out what are the diagnostic tools that we need in the first place. Who are the doctors in this country who actually treat cervical cancer? Because even though you are obstetrics and gynecology, it doesn't necessarily mean that you do cervical cancer. You might just do obstetrics, or you might just do gynecology. So what we have done is we have mapped out the country. Let me go back and talk about something like breast cancer, because that's the most common kind of cancer. Well, we have found out that I think the whole country has about 8 mammogram machines or something, which is not even nearly enough. It's not even 1/20th of what we need. So that is for breast cancer. Now, can you imagine what will happen with cervical cancer? So there's a deficit of equipment, which is diagnostic equipment. There's deficit of treatment modalities like the PET scans, the cytology. You might not even find a pathologist who even knows how to do cytology. So there's the human resource factor, where we don't have enough of those specialists. There's the equipment diagnostic factor, which we don't have enough around the country. Some regions have 0 and some regions have more. Most of the diagnostic things are either in Kumasi or Greater Accra. So if you're in the north and you develop any of these cancers, cervical cancer, they have to send you to Kumasi. If you're in Kumasi, sometimes now they'll refer you to Accra. So the whole country only has 2 places. And even in Accra, where you have places like higher level of care, like the cardiac cath, like, for instance, not chemotherapy, or you're looking for radiation therapy, there's only 2 companies, I think, in the whole country that does radiation therapy. So we have, because we've done those needs assessment, we realized that there's a deficit of everything. So the Mahama Cares was supposed to be just give them funds to support, and then we realized if you give get the person the money and they don't have the access to even the diagnostic tools, what do? So now that money is now going to augment the diagnostic tools. Then the next thing is, once we have the diagnostic tools, we need the experts to even manage these diagnostic tools. If you have a PET scan, you need the PET scan assistant or PET scan radiologist who is specifically with PET scan to even read a PET scan. Because you can have the machine, but the person reading it, for me as a surgeon, every time I send somebody for radiology, especially my CT scans, I read them myself. Because oftentimes, if I have 5 CT scans, I see that about 3 or 4 of them, they miss something. The report that comes to me, I never read it, because I do my own before I read the report, and I realize they have missed something on the CAT scan. So even the radiologist that's going to read that high-level kind of cervical cancer treatment modalities, you need those people. So it's not only providing the funds, it's looking for finding the equipment or purchasing the equipment to fill the gap, and also training, and also getting the right people, maybe training people from scratch, or augmenting those who already know how to help them, and also do research. Because currently we don't even have a national cancer registry. So as I speak today, the numbers that I'm hearing might not even be the true numbers, because we don't have a cancer registry for either any of the cancers at all. It's like a national one. So those are the things that the Mahama Cares is supposed to do. So things like cardiac, high-level things. We have like 3 cardiac centers that we're building now, one in Temale, one in Kuma, and one in, I believe, Sunyani, I believe. So those 3 places are just the beginning. Now we have to make sure that, if not nothing at all, at least every region should have some of these things. Because in Takoradi, we don't have a region, we have a regional hospital, but we don't have a teaching hospital. So every time you're in the Western region, they send you to Central region, or you have to go to Ashanti region. And sometimes by the time, most people don't make it even to Central region, let alone getting to Ashanti region. So those are some of the deficits that we have in our health system that we are trying to use the Mahama Cares to support. But that one is after you have developed the high blood pressure, you have developed the diabetes, you already have the cervical cancer, those that we know that they have, and it has been diagnosed, in how we treat them and how they go through the system. So who are even the doctors that treat it? Are all doctors the same? Because Dr. 1 might not be as good as Dr. 2. So even Dr. 1 and 2 may need extra training or upgrade of their skills, those kinds of things. So that's what the Mahama Cares on paper is supposed to look like. We are working on implementation, and I think so far so good.
Okay.
Now, at the lower ranks of the whole, our health system, in Ghana, it's the CHIPS compound to the polyclinic, and then the health center. Those are the lower ranks. Sorry, I've been in parliament all this. I'm a little bit tired. But those are the lower ranks. And on that level, we are also introducing, I believe maybe next month, free primary health care. Currently, Ghana has some level of free primary health care. Some things like immunizations, things like prenatal care, perinatal care. Some of them is free. What we're trying to more introduce and focus on with the free primary health care is more like the preventative and promotive care. Because if we're able to get that right, now we can screen for those people in the community, because our system is community, CHIPS compound, health center, and polyclinic. That's the 4 lowest rank of our health system. So anybody coming in through that level, we should be able to do a preventative and promotive.
Yeah, I was just going to ask, because I feel like you're answering the question I'm going to ask, that is the cervical cancer screening going to be part of this preventative?
That is correct. So that's where I'm getting to.
Okay.
So that we can identify, because one of the biggest problems also, even those who have it, is a late presentation. So they come in, we know they have cervical cancer, but by the time they come, there's not much we can do really. It's just, palliative care that we are providing. So at that free primary health care, preventative and promotive, that is where we hope, or we are trying to see if we can catch the people at that level. So preventative and promotive is what? For instance, a woman 25 and above. We have, of course, it's free for the people, not free for the government, because somebody has to pay for it. But we would say something like, or the package is an insurance package. It would look something like, you can get your blood pressure checked, you can get your blood sugar checked, you can also get a free clinical breast exam, and perhaps a pap smear.
Okay.
They won't happen at the CHIPS compound, but at least if it's part of your package, we can say go to this district hospital with this doctor and get this particular thing. And it's a promotive and preventative for women 25 to say 45. Now, that would check the clinical breast exam will look at the breast, and then you get and then we might even add in some tumor markers, like a CEA or something else, to pick up maybe colon cancer. And that is just a basic system. So we're doing something called, which in America we call like a well person check. So that person is when they're sick. Because currently our system works on a curative system. You get sick and then you come and you get the services. We want to get to where it's more preventative and promotive. So it's a well person check. So what age from 0 to 5, this is what a well child will get. From 25 to something, this is what a well woman, a well man should definitely get a PSA checked, a digital rectal exam. Those are the kinds of packages that we are trying to bring into. And when we hope that when we do that, we will do screening, because remember, there's a community health nurse who's in the community. They go into the community, deals with the chiefs, deal with community elders. We can also pick up the screening issues there. And let's, for instance, it will end up being perhaps the British system where every Ghanaian will have maybe a primary care physician. If we're able to do that, then you are expected to maybe once or twice a year, maybe once a year, the government can pay for a free well person check, or twice a year, a free well person check. We're still working the details, but hopefully next month, the free primary health care policy, it's already been done, and hopefully it will be launched next year. So from our point of view, that means that we'd have taken care of the preventive and promotive. And once we do that, that would prevent more people from getting up to the Mahama cares, because now they are sick and they're getting complications from hepatitis. They're getting complications from lack of early checkup. They're bringing diabetes. They're getting amputations. Now the kidney patients are getting or the hypertension patients are getting kidney failure and they're needing dialysis. If we could screen them early and catch them at the free primary healthcare level, hopefully it will be less. Now, inside the next level is the national health insurance, which at some point it doesn't also cover a lot of things that we do, and people are still paying out of pocket. We want to also curb that and see how best we can, so that people don't pay that whole out of pocket thing, because it's also a barrier to access and a barrier to entry for a lot of people. I hope I have tried to explain what we are looking at from the government's point of view, and every time I speak I try to explain to people some of the things we're doing. And so the physicians in the room, we need support. Of course we can, at the ministry level, we can't, we come up with a policy and we have the bright ideas, but the people that actually implement it are the people in this room. So it's consultative. We are open to ideas, what is the best way, so that as Ghanaians we could all enjoy very good health care. So of course we're buying equipment also to fill in the gaps, for both at the level of the free primary health care, because you don't want to go to a CHIPS compound where they don't have a SFIG. You don't want to go to a CHIPS compound, where the thermometer is broken or the scale is not there, because these are all preventative and promotive things that we can do. So we are retooling almost all that level at the free primary health care level. And so we're also retooling at the level of the patients that would need the Mahama cares. So we are really working, and we've done our needs assessment in all the hospitals, most of them, and we kind of have a roadmap, and hopefully, by God's grace, we will get there.
Thank you very much. I want to see it in my lifetime, so please let it happen. But I think you've touched on almost everything that we discussed here and what we are hoping to see from our governments. Before you walked in, I must say that I said we should hold our governments accountable because we pay taxes. And so we should expect that the average Ghanaian gets the care that they would get somewhere in Takoradi compared to someone in Accra. So thank you very much.
Thank you.
Okay, so we have just about half an hour to go, so I'm going to try to see if we could do a speed round, but also start with Joseph. What would it take? What would it take for, say, private health insurance? What would it take to make it, because we've identified cost for the screening as one thing. What would it take to make private health insurance take it on at the cost that the average person who's paying for that private health insurance doesn't feel like, oh, because I have to do this, I'm paying X, and it's a bit too much, so still I don't want to do it.
All right, before I answer that, just a quick one. Thank you, Doc, for that intervention. But just to confirm that for in terms of some of these policies and programs, sustainability is very key, and consistency. So just to be sure in terms of funding, how it's going to be done, so that we know that when it starts, say, under this government, because we know that, anything on consolidated fund, when someone comes, you want to see how we can hike it up because I didn't start it. So is there a legislation around it so that we know that it's going to be consistent going into the future? Before I answer your question, just to...
Thank you. Yes, we'll have legislation around it. Okay. And unfortunately, I'm not a finance person. I go to my consultation room and I don't know. All I know is I bill for my services. And even if they pay me all of it, I'm not even sure how much they pay me. So unfortunately, I don't know much about finances. but we do have like financial experts who are, health insurance experts who are a big part of this, because this is all about funding. And as we have discussed over and over again, I think every topic is about how the money to pay for it. I think yesterday the Mahama case, they got, I forgot the amount, but yesterday the budget was approved by Parliament. How much? 2.9 billion for Mahama case that is there, and it's been allocated for them. And the retooling for the these, especially for the cardiac centers that I talked about, is they have already started. They've cut sword. The retooling of the equipment in terms of mammograms and all that has already been done, and they brought a comprehensive budget. And the parliamentary committee on health evaluated it, and they have actually passed it as of yesterday. So the same thing will happen with the free primary health care. Everything will be put to public scrutiny and then go to all the committees and the parliamentary committees before these things are passed, because it's about money. And also remember that these funds we're talking about is everyone else's taxpayer money. And that was one of the reasons why President Mahama wanted that free primary health care, because he figures that every Ghanaian pays that levy, NIH levy, whether we buy Coca-Cola or whatever we buy. So at some point, it should offer every Ghanaian a little bit at the lower level. Once you pass the health center, you are no longer on the free primary health care. So if your referral goes to like a tertiary hospital, then now is your NIH that kicks in. But at the lower level, he wants every Ghanaian to have at least a basic, if not super comprehensive, it is a basic health care that should be guaranteed for every Ghanaian. And this is all towards Universal Healthcare 2030. We are almost there. We're now in 2026. So 2030 is right around the corner. And so we're working on it. And at some point, the declaration and how much we put into the health fund would have to also looking at see how best we can adjust it and keep going. We have reached a 15% allocation for health, and Ghana is seriously looking at it and see where else we can get funds. So that's all I can say. I wish I could give you more financial details, but I'll get lost in the middle somewhere.
Thank
All
you.
right. Yes, yes, but this information really helps, especially because for private health, as I said before, a number of the things that we do is more complementary to what the National Health Insurance Scheme does. And so if this is going to be a policy that will be rolled out, what we are able to do is to hook onto that. But I can speak for my scheme. As I indicated earlier, we have this as part of our packages. But of course, the screening is a cost that we bear on behalf of the members. And so if we are able to have that of the national health, and then we can ride on the back of that. If we are able to have education go down well with our women, and then it becomes a bit easier for us to be able to take part of the cost, because we cannot take all the cost. Take part of the cost, and then the other part that we know that can be managed by the insured members, and they are able to come on. Because if education doesn't go on well, the member will ask that why do I need to pay a little bit extra for some of these screening to be done for the member. But if the member is already educated about it and all that, it becomes a bit easier. And for some of us that do more of the corporate, it becomes a bit more easier conversation, because the employer is already aware. Those at the top of making decisions for the corporate institutions are already aware. And if it becomes a national policy, which we are able to implement it very well, it becomes much easier for us to go around the table and then have conversations on covering it under the private health insurance.
Thank you very much, Joseph. Okay, so now we'll do it like 2 minutes for each person. Oh no, a minute actually, because we are almost at the top of the hour. So, Abena Yosin, And same question for Abna, Asmeni, and possibly I think Auntie Susan and Ifia. What would you change if you could tomorrow to make screening for cervical cancer happen, so that we don't get to that point where we are still having people report late when they've already developed the cancers?
So I'll start by saying that I believe delay is a choice, and choices have consequences. And delay is a choice in this case because
Isn't it rather because of the cost?
I am saying that because we can look at other ways of being able to reduce these consequences. Screening is one of them. That is why I say delay is a choice. It comes at a cost, and that is why we are discussing possibilities of how we can also. I like what you said, where you said we should consider, restructuring these, the insurance or the component where we waive or we take some off treatment and then now get some funding for screening. Like it or not, in the rural areas, there are people who really need to be screened. They have no clue about what is happening. This is tied to awareness, education, so there are a lot of things we can do, we can start with, and that is why I'm still sticking to what I'm saying, that delay is a choice. Okay. We can start from a point. Right. And so we need to start from awareness, making sure that everybody at least has information and understands what we are dealing with, and also make screening something that becomes a personalized self-care, so that people can be responsible to also take the necessary steps to seek that screening.
Okay.
Thank you.
Thank you, Abna. Abna Asmini.
Right. I would start from the point of view of awareness, that a lot of investment must go into that. That people know, nobody wants to die. That somebody knows that they can have this or they have symptoms of this, and they'll say nobody wants to die. And so if they know, they would attempt. And then the second is trying to make it accessible also. Information is what I've mentioned. But the other part is how, when you look on your bill, you see that syringe is this cost, consultation is that. That line item for screening can be separated and made free. But of course, it has to go through policy. It's a big ask, but we are allowed to dream. And so the ideal situation is that when women know that it's not going to cost them that much, they would access it. Look at all the campaigns that we've made around breast cancer. And then that part about the freeness of the screening. When you go to church, they are screening you for free. When you go to the hospitals, the Pink Month is allowing that access to happen. And it's a beautiful thing. So some strides are being made in that area. The last is also the stigmatization, which is very important. That, when somebody has cervical cancer, oh, she must have slept with so many people, But it comes back to the first point. When people are educated well, you can demystify that whole space, and not make patients feel like they are sluts. And that's how come, a bit like, you deserve what you did. You slept with so many people, particularly for that early stage where we are catching them young through policy. But those who have already gone through, we need to find a way to let it be something that if somebody has it, it's curable, you're not going to die. And that's it. Yeah, thank you.
Okay. And Susan, you want to go before? If yeah, then we'll come to you after her.
Sure. Well, I mean, yes, awareness creation is important. I think maybe what we need to do with what we did with HIV earlier, social marketing. There has to be a lot of social marketing. Health education should be about making people aware that they are susceptible, making it, for want of a better word, sexy, so that people can relate to it. When we did the social marketing with is it what's love got to do with it, or it takes two, or whatever it is that all of a sudden HIV was in your face, and you could relate to it because we had people that we could relatable people like Pusha, etc., etc., talking about it, and so we need to make it relatable. The health education should be such that people can feel and know that they are susceptible to the disease. So we need to look at it, and we want to also encourage the government in terms of in low resource settings, especially politicians, they like to see infrastructure that is tangible, and sometimes screening programs are not so tangible. Same with vaccine. I mean, we always say vaccines are their own enemies because you prevent the disease from happening, and so when it doesn't happen, people don't value it as much as when the disease happens and you're treating it. And so sometimes things like vaccine are their own enemies because of their success, but we need to let politicians look at it. We need to find agenda setters. When we set the agenda, the politicians will want to push money in screening, and so we need to do that. But we encourage them also to build the infrastructure, because the deputy minister has said it, the infrastructure is not there. The lab infrastructure is not there. The human resource infrastructure is not there. Because if the person in the village does not have access to somebody who can read their scan, or can do some screening program, then what is the point in getting them ill and then treating them? So we need to do all of these things. But like I said, let's have a national program, like how we do have a national program in terms of eliminating malaria or eliminating guinea worm, etc., etc., etc. And then maybe we will get everything.
Thank you.
Okay, so I'm going to touch on one thing that Dr. Nikwe said: the health-seeking behavior of Ghanaians. And for half of my life, so like the first time I had a gynecological exam was when I was around 26 years. And I had it because it was mandated by my health insurance. When I started work, I had to have a full woman examination. And so I saw a gynecologist, and the gynecologist was so shocked that I had never been to a gynecologist at 26 years. So obviously it wasn't here in Ghana. But that visit, they found abnormal cells on my cervix, rushed me to surgery. That was 25 years ago. If I hadn't done that, because I don't have kids, I wouldn't have gone to see a gynecologist when I was going to be pregnant or want to be pregnant. It would have been a missed opportunity, and I definitely would have turned up with cervical cancer. Our health-seeking behaviors are, we don't look for things that we do not want to find or waste money on. That is a cost that we have to look at, changing that perception. Then if we want to have it as a structured thing that everybody sort of goes through, that filter of a health check, let's look at the systems that can enforce that. Let it be mandatory when you start work in the bank, you start work anywhere, you start work as a member of parliament to get a screening. Our health-seeking behaviors don't let us voluntarily get up and go and do screening. So it has to be mandatory, and I say that quote unquote because according to our constitution, it's you have the right not to go and do it, but we have to be shoehorned into that place where we have to know our health status at every point in time. So the cost, definitely, in education, insurance would have to bear it at some point, and the government, of course, because not everyone is going to have to go, will be able to go through the filter of unemployment to get it done. But we need that structure to make sure that we don't slip through the cracks.
And for health professionals, you have the last say before our Honorable Deputy Minister. What structural, Dr. Hala, that includes you too. What structural gaps need to be filled for to fight? Like, maybe, I don't know, we can go, maybe Frederica, you would want to start, or we could start with Felix and come this way. Who is ready? Okay.
So, your last question, there's a 90-70-90 by WHO, which you are supposed to achieve in 2030. So for the first 90, that's vaccination just started. So we have a pass there. The next 70 years, that screening, 70 women, eligible women, 35 to 45 would have been screened. The last time I checked from data, we are at 3.5%. So that we are not there. The next one is 90% of those who've been diagnosed will receive treatment. Okay, by 2030. So we all have a lot of work to do. I must say that most OBGYNs, which we have in almost every part of the country, can diagnose cervical cancer. Also, there are different modalities of screening. Unfortunately, we've talked about the standard ones, which are expensive. There's a VIA, like you mentioned, and those ones don't necessarily need a pathologist. And those ones are usually done in the outskirts and some parts in the urban area. So they stain the cervix with acetic acid or vinegar or used for salads and things, and based on the changes, you treat. So some of the treatment is either you are using thermal ablation or you are using cryotherapy. Those ones are portable machines, so they are easy to do. So that's by the way. But what we can see, like from our advice, is that we can make cervical cancer, that's when the cancer has been diagnosed, a reportable incident. So that people who are diagnosed with cervical cancer, from there, we have 2 main government centers that treat, that have almost everything you need to treat. So they are buzzed to the treatment centers and get priority in terms of treatment, because the truth is this: you just see the cancer buses carrying patients from different states, or to, let's say, Tata Center, because Tata has been designated as a place. If you can do something like that, there's hope. So they don't spend their money in traveling from Wale Wale all the way to Kumasi, and Kumasi is broken down, and they'll come to Kolebu, and it's expensive. So that's my.
Thank you.
Thank you.
Yeah, okay, Frederica.
So before I start, I wanted to mention something that she talked about regarding the breast cancer. For example, the fact that there's a lot of noise about breast cancer and there's free screening for breast cancer. The screening for breast cancer is just, I'm touching your breast to see if there's anything inside. It's free. Like, I mean, you don't need to pay for that. But if we are talking about free screening for cervical cancer, the sample is usually taken to the lab where the person needs to pay for, and that's where the problem is. Okay, so that's why we need money from elsewhere to be able to do free screening for the people, because it can't be free like that. Even the VIA, you need to buy the acetic acid to use, you need to buy the speculum and all that. Unlike breast cancer where you can just put her down and do that. So at least that's one thing that makes cervical cancer free a bit difficult, and also the reason why we need the government in it. And talk about the peripheries like Dr. Nikwe mentioned. The VIA, for example, I think that in most of the district centers, if we have a lot of the health team trained on even just the VIA, it would help. It would help in the sense that, well, it's the first kind of screening you can do, and one of the cheapest actually. Okay, you can have VIA done for as low as 30 cedis, whilst the pap smear and some other hospitals go as high as 200. The HPV testing goes as far as 500 cedis compared to just the VIA. So for those who are a bit concerned about how much money to spend on the screening or what to do about the screening, a VIA is easier. And if training are done in most of these places, it helps because then as soon as they do the screening and they think that there is something, even if they are not sure, they refer. And that will be easy for us to take it up on before the cancer starts.
Okay.
Because even with the VIA, it's not just cancer, it's just the pre-cancer changes, which is easier to treat.
Okay. So we have 9 minutes, and there's a question from online. So we have 4 more doctors and the health minister. So, hey, we'll do the division. Yes.
Okay. So another aspect I would like us to look into is social media.
Okay.
Yes. Now everybody has TikTok. They have Instagram. They have X. They have Snapchat. Facebook. They have all sorts of social media handles. So we as healthcare workers, I think one of the things we can also do is to have these short clips. We talk just about a minute of data has shown that people lose interest when a video is more than 2 minutes. So we can have these short 30-second clips or 1 minute clips, talk about them. I have a program on Facebook and Instagram called Time with Dr. Anita, where I was talking about women's health. So we could all employ stuff like that. You don't even need to get any expert, just take a nice phone, make a short video of whatever you want to talk about. We talk about them. We will get the adolescents, we will get the early adults to listen, to watch, and then at least they will help to improve their health-seeking behavior. Yeah, right. And then that's a bit about my side.
Okay.
Yes.
Thanks. Dr. Felix, Charles, who wants to go? Yeah.
Okay, so just to add on to what Dr. Nita said. Yes, so now we have a lot of radio stations and TV stations in the country. We can leverage on that. But we as health workers need to know what we are going to talk about. Okay, so most of us may not have much knowledge in cervical cancer prevention and all that. So that's where the education also comes in. We can talk to the public in the various languages, Ewe, Chi, Hausa, whatever language that we can. I think that will help. That's one. Secondly, we need to start from the top, from the national, then down to the community, then the individual. Deputy Minister said a lot, and I'm quite happy with what she said. If even you put NGOs, other corporate organizations to help in these outreaches, then finally the individual, as Ifya said, yes, our health-seeking behaviors. Yeah, it's a big thing. It's among the literate and the illiterates. Yeah. Both. Absolutely. It's difficult to actually try and take that thought from. It's difficult. Yeah. I see my patient. You tell them, "Oh, come in 2 weeks' time because we need to do this," or "Come in a month, we need to do this." Don't come. They'll come in next 2 months. You tell you, "Oh, doc, I thought I was fine." Blah 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 blah. Things like that. So for that aspect, it's going to be difficult, but little by little, we'll get there.
Sure. Yeah. Dr. Ninije.
Okay, so just 30 seconds. I think it starts with a confession. I must say, when I'm seeing my stroke patients, the last thing that comes to mind is the cervix. And I'm sure a lot of physicians would be in my bracket. So it starts with, consciously talking about the cervix. The hypertensive patient, the one with the kidney failure, cervix doesn't come to mind, to be honest. So, I have to go a step further to look at the cervix in addition to all the other.
Okay. No, Dr. Yesu Danko.
So, sorry, I wanted to add one more. 20 seconds. So, with the social media influence, and if we could get a lot of people, you see, there are a lot of influencers who talk about things. With breast cancer like this, you get people who come and say that, "Oh, I'm a survivor of breast cancer," and all of that. But unfortunately, we don't get people coming out to say, "I'm a survivor of cervical cancer," because of that notion that, oh, it's sexually transmitted, which means that you probably got it from somewhere, you got it. So we are not getting people who are advocating for it. If we have the advocacy, I think that would really help.
Thank you. So, if I've heard everybody in the room, it has to do with, I think, community engagement and also public education. Um, for our free primary healthcare policy or program, public education is key because you can still offer the services and say come for free and people won't come. So we actually have to drive the demand, and driving the demand would mean, most in Ghana, most of the communities have community health nurses. And they are in the community talking to the assemblymen, talking to the chiefs, and really in the community, dealing with the community. And that is where the public education starts, with social media as well as everything else. However, though, I think that when it comes to cervical cancer, we need to operate with data. Everything has to be data-driven, and it has to be evidence-based. Most of what I hear here is sort of anecdotal, like, my patient and my patient. We need to have a real cancer registry. Like everywhere else, if we don't have the full picture and the full data, whatever we do will be not sufficient. So I feel like before we start, we need to go back to the drawing board and do a proper cancer registry for breast cancer. And that would mean that the community health nurses, sometimes even if they haven't been, what I say? Oh, sorry, cervical cancer. That means that sometimes even if the person hasn't been to a hospital, people in the community know. They can tell you, family members can tell you. So let's get back and really get a proper cancer registry. Once we do that, we would know the true numbers of cervical cancer. And once you know the true numbers versus other types of cancer, that's how you can allocate funds. And if you say that somebody is coming for free primary health care, you need to, for the neurologist who said the cervix, he's confessing that the cervix is the last place he would look. If we put it in as any woman that passes through any hospital must at least get a breast cancer and the clinical breast exam and their cervix checked. Those are the two cancers. If we can eliminate these two or reduce the numbers of these two, cancers in Ghana will reduce. Every man, regardless whether he has neurosurgery, he's coming for plastic surgery, he's doing a burn surgery, needs his PSA as well as a digital rectal exam done. If we are able to know that as physicians, at least those top two, it will eliminate a lot of cancers in this country. So those are some of the discussions we're having at the ministry level and at the policy level, and trying to incorporate those things into our free primary health care and ultimately into the Mahama cares. It's a tall order, but we are aware of the issues and we will do our best. The president is extremely adamant about health. Okay. He wants to anchor everything on health, the health of Ghanaians. So
thank you, Honorable. Unfortunately,
we will get there soon. Thank you.
Thank you. So we'll take the Dr. Ella's closing remarks and then I'll wrap up quickly.
Okay.
Seconds, I guess.
What we are talking about is real. Is the woman who travels with a stench. We all know that stench. Sits on a bus to come for treatment. You can smell it. Everybody's looking at her. She's stigmatized. She comes for radiotherapy. She lies down. 4 men, technicians, put in a probe, and they are hoping to make sure that she's cured. Her dignity is gone. We don't want to get to this point. We want to prevent it, and we want to make sure that our girls, and boys are vaccinated. Yeah. So that we prevent it from getting to the point where the woman is stigmatized and dies even after all of this stigma. Thank you.
Thank you very much. I want to say a big thank you to all our resource persons for joining us tonight for this conversation, and for those of you who joined us online. Sorry we couldn't take that one question that came through, but you can possibly send it to us again next week, because next week, Wednesday, which is the 18th of February, we'll be here again, and the topic for discussion will be, should men be held responsible in the fight against cervical cancer? 7 p.m. on the dot. We'll start right here at the Debate House. It's in collaboration with QIC. My name is Nia Kofi Smatabi. Thank you so much, Dr. Ella, Abna Yosin, Frederica, Dr. Nikwe, Ifiapia, Dr. Nita, Joseph, Dr. Charles Sosu, Abna Sweeney, Dr. Felix Anineje, Honorable Deputy Minister, and Auntie Susan. Thank you so much for joining us. And we'll see you next week. Bye-bye. I know.